Thank you everyone for giving me this this wonderful opportunity. I am myself Dr. Tejaswidas. I am final year PG in Kilpauk Medical College, Chennai, and my guide me Dr. Sudha Salamoni ma'am, HOD of Kilpauk Medical College, and mentor being Dr. Lakshmi ma'am, Osmania Medical College professor. My case is a 10-month-old female child with a resident of Nungambakam came with the chief complaints of split in the right side of the lip since birth. And history of present illness, patient was born with split in the lip on the right side, and there is no frequent episodes of fever, cough or sore throat. No history of ear infections, no history of any other anomalies, and developmental milestones are adequate to the age, and immunization status is up to date. Hello?
Your slides are not moving. Your slides are not moving. It is stuck with first slide.
Yes, ma'am. I'll see. Again, I'll share. Is it moving, ma'am?
Yes, they are
moving, ma'am.
Yes, they are moving.
Yes, ma'am. My patient is a 10-month-old female child, resident of Nungambakam, Chennai, came with the chief complaint of split in the right side of lip since birth. And patient is born with split in the lip on the right side, and there is no history of frequent episodes of fever, cough, and sore throat. No history of any ear infections. No history of any other anomalies. Developmental milestones are adequate and immunization status is up to date. Antenatal history. Child is born with a full-term normal vaginal delivery of a consanguineous marriage, and the child being his second child, where first child has no anomalies. The age of mother and father at the birth of the second child were 28 and 30 respectively, and no history of any drug intake like anticonvulsants and retinoids or folic acid, and no history of fever, no history of radiation exposure, or no history of smoking in the first trimester of pregnancy. Family history, there is no similar complaints in the family. Past history, as soon as the birth, the parents were counseled about the feeding protocols and also the counseling regarding the procedures which are to be done in the future. General examination. The patient is examined in a well-lit room and proper consent is taken from the parent. The anthropometric measurements are height being 68 centimeter, weight 9 kgs, which are appropriate to the age of the patient, and BMI being 19.5 kg per meter square, and Karnofsky performance score is 90%. And patient is adequately nourished and hydrated, and child is alert, active, no pallor, no icterus, no pedalgma, no clubbing or no lymphadenopathy, and vitals are within normal limits. Other systemic examinations are normal. Calvarium, vertebral, anorectal and limbs appear to be normal. This is the case. A local examination of lip. There is discontinuity of the lip is seen in the right side, and there is discontinuity of the white roll, and apex of cupid bow are raised on the cleft side. Muscle bulge is present on both sides, and the lower lip has a single pit without any discharge. Nose examination. The nasal sill appears slightly wide on the cleft side, and nasal floor appears normal. Columella base is slightly shifted to non-cleft side. Tip is bulged and slightly deviated to non-cleft side. Alar flare is present, and nasal septum appears to be normal. Alveolus and palate appear to be normal, and dentition did not appear. My diagnosis is a right side unilateral incomplete cleft lip with mild nasal deformity with syndromic association, that is Vanderwood syndrome, and classification being group 1 cleft according to Nagpur classification. Modification of Nagpur classification, group 1 PR. Thank you.
Bhattacharya sir, Debrathi madam, you'd like to ask anything in history and examination?
What about the alveolus? Because
alveolus, I described, sir, it is normal, sir.
Really, you should evert the lip and show to the audience that because apparently it is going. In some of these cases, there is a notch in the alveolus, so
Yes.
which you should mention.
Yes.
And can you describe how the upper lip is developed?
Upper lip is developed from the upper lip is developed from the maxillary process. The lateral side of the upper lip is formed by the maxillary process of the first pharyngeal arch, mandibular arch, and the frontonasal process, which forms the median nasal process, which forms the middle of the upper lip.
So it is the union. Why there is a failure on one side?
Failure of one side is due to lack of union between the median nasal process and the maxillary process on one side.
Yes, correct. The columella is central.
Sir, in this patient, sir, in the columella is slight deviation, sir. Slight deviation to the non-cleft side.
Yes. Why there is a bulge on both the upper lips?
Sir?
Why there is a lateral bulge?
The lateral bulge is on the cleft side is due to abrupt end of the muscle.
Which muscle?
Of orbicularis oris. Sorry, sir. Orbicularis oris, sir.
So what are the segments of the orbicularis oris?
Orbicularis oris has three parts, sir. The first is the superficial or deep part on the vermilion border, on the vermilion, and the pars marginalis on the vermilion border, and the pars peripherales on the philtrum and around the lip.
So what is your aim of repair?
The aim of repair is to align the philtral columns in exactly in the middle, and also to bring the lip white roll in alignment.
So it is the functional and aesthetic result.
Yes, sir.
So when we talk of functional, and there are few types of fibers of the orbicularis oris. Which fibers give which expression? What are their functions? Unless you know this, postoperatively you will not be able to assess all those functions. So which fibers functions in different way to give different function to the lip? Can you correlate mathematically?
Superficial fibers are for the expression, sir, and the deep fibers are maintaining the aesthetic appearance, sir.
What about sucking? What about whistling? What about wide smile?
Pars peripherals, sir, which makes the lip to purse and useful for whistling, sir.
Okay, Dr. Chattopadhyay.
Shall we discuss the management?
Yeah, can you?
Yeah. So what is your plan for management?
I would do investigations, routine blood investigation for the patient, and since the patient's age is 10 months, the age criteria it crossed the 10 weeks barrier, and the weight is more than 5 kgs. and the hemoglobin, I'll see the hemoglobin should be more than 10 grams percent, and TLC count should be less than 10,000, sir. And after doing investigation, after getting routine investigation and anesthesia assessment and fitness for surgery, I would mark the counsel the parents regarding the surgery, and I would
you have to investigate for other congenital anomalies and exclude also. Okay.
You already said he has a syndromic association. This is a Vanderwood.
Vanderwood
So what
syndrome.
else would you look for?
The Vanderwood syndrome, the cleft lip, involvement of cleft lip and palate, and lower lip mostly pits are present, ma'am.
Okay, but for any syndromic association, what else? What investigations do you need to order?
Genetic, the chromosomal analysis should be done, ma'am.
That is fine, but physical examination, any other investigation, what would you look at?
Yes, ma'am. I would
Cardiological.
cardiology. Yes.
Yeah.
I would do cardiology workup, ma'am, and ultrasound abdomen, and for renal problems, there is a most anorectal, renal, and limb, and the vertebral anomalies are commonly associated with the syndromes and cardiac anomalies, ma'am.
Yes. So how will you manage this case?
After getting
What is the operative planning?
Operative, ma'am. I would proceed with Millard advancement routine rotational advancement kiloplasty, ma'am.
Can you tell me the equations of Millard? The 4 equations that you have to put in your measurement.
First I would mark the points, ma'am.
Yeah. Can you show us by your cursor?
Yes, ma'am. The first point being on the non-cleft side, the filtral dimple, ma'am. The Cupid's bow lowest point is marked as 1, and the immediate the apex of the Cupid's bow is marked as 2. The first equation is 1, 2. It should be equal to the cleft side filtral the distance between 1 and 3rd point we are going to mark on the filtral column on the cleft side.
How do you mark that? How do you mark that? What anatomical structure gives you some idea of marking? There is something in that anatomy which gives you a clear idea about marking that point 3. What is it? What is the Nudolph's point?
Nudolph's point is 0.4, ma'am, on the
that is fine. So Nudolph's point is on what? It's on the white roll. So is there anything on the white roll that will give you an idea of how to mark that point 3?
Yes, ma'am.
What?
The end.
Is there some breaking? Is there some breaking?
Muscle breaking of the
white roll.
White line. White roll. And fourth point is marked as a columnar base, and alar base is 5, and the lateral commissures are 6 and 7, and 7th point is the ending is the fading of the white line, or the maximal width of the lip on the cleft side is marked as Nodolph point.
8.
And this is 8, and ninth point and 10th point being on the columnar base on the cleft side, and ala on the left side, on the cleft side.
So this is an incomplete lip. Are you going to touch the nose?
No, ma'am.
Sure.
The incision should be made, ma'am, but the C flap and the flaps used for correction of the columnar base, that need not be done.
So you're going to keep the nasal sill intact, or are you going to do something about that? Are the width same?
The width, there is width difference, ma'am.
So how will you manage that? Your 0.9 will go up to what? In clear cut, complete lip, you know. But in these cases, how would you extend your pairing incision? Where will your 0.9 go to? Are you going to excise a part of the sill to make the sequel?
No, ma'am. Actually, it's almost equal, ma'am. After the rotation advancement, if the nasal cell appears equal, the tissue need not be cut. If there is any difference, a small part of the
Small
nasal cell
particle may be excised.
excised, ma'am.
Okay. So are you doing the Millard 2 or Millard 1 or Millard 2?
Millard 1, ma'am.
Millard 1.
A back cut is not given.
You are not giving a back cut.
No, ma'am.
Okay, fine. So after you've raised the flap, you're finding when you have sutured the muscles, you are still finding there is a 2 mm gap between the 2 mm difference in height between the two sides. What are you going to do?
Then I will give a back cut of 2 mm, ma'am.
Okay.
Then back cut of 2 mm and cut on the muscles from the all the the origins on the cleft side are separated.
Where are they attached? Where are they attached?
Yes. The on the cleft side, the orbicularis oris muscle is not in continuous with on the lip. It is attached to the nasal spine and ala and ala ridge and piriform sinus.
Medial side, what all the structures these muscles will attach?
Medial third to the columella base, ma'am. Nasal spine.
Yes.
The nasal sill and the ala, ma'am. Ala.
Ala is lateral. What about medial? Medial, what are the structures? Of
Nasal
course, this
spine.
is the incomplete, but if it is a complete lip, where they, what all the structures, it is muscles will attach. It's a abnormal attachment, isn't it?
Yes, ma'am. Piriform nasal spine, medial nasal spine, and columella base, ma'am.
And even the part of caudal septum also.
Okay. Nasal, yes, ma'am.
Okay. Right?
Okay.
In a wide cleft.
Ma'am?
Okay, you go ahead.
Yes, ma'am. After this markings, I would tattoo the markings and tattoo the markings preoperatively.
What is the instrument you use for these distances, to measure this distance?
What is it?
Caliper.
Right, it's a caliper.
Yes, calipers.
Yes.
Yes.
How do you tattoo it, Dr. Tejaswi?
I would use 25 gauge needle, ma'am, and dip in junction violet and tattoo it.
How? Dip in junction violet and mark. Okay, fine. Okay.
Have you marked any markings you did?
Sorry, ma'am, I did not do this marking.
Okay, right.
After marking and after giving anesthesia, I would infiltrate the all over the markings with Tunisen solution, which contains 1 in 2 lakh adrenaline and 0.5% lignocaine and 0.25% bupivacaine. After infiltrating, the incisions are given ma'am, with 15 number blade. Initial incision is given, and the after dermal incision we use 11 number blade to go deeper into the muscles, ma'am. Shall I continue, ma'am?
Where does the bleeding appear? As soon as you give the incision over the lip, Where is usually the usual point of bleeding?
Usual point.
How do you control the
Okay.
bleeding? Rather, if I rephrase, what is the anatomy of the superior labial artery?
Superior labial
What is the
artery on
location?
sides
Location.
comes along the
No.
the wide.
Tejaswi, when you
Yes.
cut the lining, that mark,
Yes.
so where exactly you will see the bleeding point and how will you control? That's what madam is asking.
Is it between the muscle and the mucosa and the skin? Where is the point? There's a very typical point. These are things, if you have seen it done, or if you have done it, you can answer, basically.
Mucosa and muscle, ma'am.
Yes. Or within the muscle.
Within the muscle.
Either it is within the muscle or it is between the mucosa and the muscle.
Mucosa, yes, ma'am.
Yeah.
So on red line.
Ma'am?
It is in the red line.
It's
Red
in the
line. Red
yes,
line.
yes, ma'am.
Okay. How do you proceed?
After incising, the muzzle from the abnormal origins are separated from their insertions and brought into alignment in the center, and the cleft side is advanced and the non-cleft side is rotated to bring alignment of the white line and the white line and the filtral column in the middle. Now the muzzle after getting after making in the alignment of the white roll, the muzzle the first key stitch is made on the white roll such that the white roll is maintained, and the muzzle the orbicularis oris muscle is sutured in 3 layers. The first layer is a muzzle layer with using 40 vicryl, and next it is the skin is used with 40 proline, and the mucosa is with 40 proline.
Okay. Okay. After stitching, after this, you said if you find some discrepancy after the muscle is sutured, you give a back cut.
Back cut.
So you're converting it into Millard 2. So what is the difference between Millard 1 and Millard 2?
Millard 1, the back cut is not given, ma'am, and Millard 2, the back cut is given.
Say what is given. When you are asked like this, say what is added rather than what is not.
After the marking is made, ma'am, the extra back cut that is equal to the defect size is given along the incision on the non-cleft side.
How do you know, Tejaswi, beforehand how much has to be lengthened?
The horizontal the transverse lines are drawn at the Nordhaus point and the point 3 of point 3 on the non-cleft side, and the difference is known as is considered as a defect.
Okay. How can you further lengthen the lip? You've given the back cut. What is the limit of the back cut? How far you can go on the opposite side?
Till the columella base we can go, ma'am.
Will you go to the opposite side?
Not opposite side, ma'am. They should not pass the filtral.
Columella base means columella base is opposite side, isn't it?
It should not cross the opposite.
Cross the midline.
Cross the midline. Yes, ma'am.
So now, still then, your lip is short. So what can you do? There is some discrepancy at the vermilion border. You've given the back cut. Now what will you do?
If there is to lengthen, there are the additional triangular flap can be given.
Where?
At the lower end of the filtral column, ma'am.
What is it called? Lower end of the filtral column. It is a flap at the white roll or flap above the white roll, right?
Just above the white roll, ma'am.
Right. Or a flap at the white roll had also been used, whatever you are comfortable with. Any other way this can be lengthened? You said to the columnar base. Can
Yes,
we
ma'am.
go to the nose?
Yes, ma'am. Muller's modification.
Yes. Yes.
Yes.
There the back cut is put into the nose.
Into the nose, ma'am.
Okay. So how would you finally match the vermilion? You matched the lip, the vermilion border. Now
Yes.
there is some discrepancy at the vermilion and the free border. Now
Yes.
what will you do?
There can be a triangular flap also can be given on the vermilion, ma'am.
Which side? Lateral, medial?
On the medial side, ma'am.
What?
Once, ma'am.
No.
Ma'am. Hello.
What? It is called something V flap, a lateral V or a medial V?
You show where you will give.
Yes.
It's a lateral V. It's a lateral V.
Lateral.
Yes.
Yeah. Remember one thing, in cleft, the medial side is deficient. So
Yes,
whatever tissue that we are stealing from the lateral side.
Yes, ma'am.
And whatever opening up we are doing, we keep on opening up. In Millard, we have that advantage. We keep on opening up.
Yes,
So
ma'am.
the tissue is short, we open it. We put triangles from inside. Now, wherever you want to put triangle, on that basis, lip has been named. There has been different names of different authors who put the triangles from below the nasal sill up to the white roll. There's been different triangles, but basically it's the medial side deficient and the lateral side excess. So whenever it is, you're putting any V, it is on the lateral side.
Lateral side. Yes.
Or a Z-plasty in the dash mucosa, where either you put a lateral V or you do a Z-plasty. Where do you do the Z-plasty?
Additional tissue on lateral.
No, Z-plasty in the dry mucosa, wet mucosa.
Dry mucosa, ma'am. The wet mucosa, ma'am, inside. Wet mucosa. Yes.
Okay. What would you do post-operatively?
Post-operatively, the first thing I would ask the daily dressing, daily the sutures should be wiped with a paraffin gauze, such that the scab should not be present. And second thing, the feed should be started immediately post-operatively.
What feed? How?
This palliative feeding can be done, ma'am.
Okay. What feed? You will allow all food?
All food, ma'am. Hello?
No, usually we don't encourage bottle feeding immediately. Usually there are many ways. Usually a palliative or a spoon feeding is allowed initially.
Yes, ma'am. And the next thing is the suture removal should be done on the 6th or 7th day, ma'am.
Under GA.
Under GA, ma'am.
Otherwise, you can also put absorbable sutures. Instead of proline, in our center we use absorbable sutures for the lip.
Okay.
Which doesn't have to be removed.
Yes.
Vicryl rapid.
Yeah, rapide. So we give 3 layers actually. Muscle, then we give a strong subcutaneous layer with 5-O-Vicryl. Then with 6-O-Vicryl, we give very few, for 4-5 stitches, which just gets absorbed in 4-5 days.
Yes, ma'am.
Then you avoid the second GA procedure of the child.
Yes, ma'am.
Sir, anything?
Actually, our guest has come, so he left the meet.
Okay.
If the case finished, we'll go for waters. Do you have any questions, Tejaswi?
No, ma'am.
Do you have any doubts? You can ask.
Ma'am, regarding Vanderwood syndrome, ma'am, actually, because it is not when the patient has no discharging pit over the lower lip, is any intervention, because only aesthetic, if the patient requires only aesthetically we can correct the lower lip, ma'am. Is
Yes,
there
Yes.
any?
yes.
and And also, I want to tell about the, Vanderwood, ma'am. Vanderwood syndrome. If there is any inflammation or chronic discharge from the patient from the pit, there is predisposition of squamous cell carcinoma. So that is the only indication for uh,
Excision.
excision, ma'am.
Yeah.
Yes, ma'am. In this patient, I would counsel the
Yes.
patient regarding that also, ma'am. Patient parents.
Yes.
Yes.
Okay.
Okay. Nice,
Thank you.
Rajeshri. You presented well
Yes, ma'am. Thank you, ma'am.
and answered well.
Yes,
Sharik,
very nice presentation.
Thank you, ma'am.
you prepared well. Sharika?
Yes, madam. I'm trying to share my screen also.
Yeah, yeah. Kilpauk Medical College, you just tell the diagnosis and the treatment for each quarter. Dr. Sri Kumar sir is available in attendees. Sir, request you to contribute your experience, sir.
Yes, madam. Good evening.
Good evening, sir. Good evening.
Good
Good
evening,
evening,
madam.
Sir
Yes.
is Professor HOD at Manipal Hospital. Very senior plastic surgeon. Sir,
Good afternoon.
anything you
Good
would
afternoon.
like
Good afternoon.
to share your
Yeah,
experience in
yeah.
anatomy?
Regarding the first presentation by madam regarding pharyngoplasty, the little bit of the difference of opinion is because as Bhattacharya sir said, we use the return flap for the from the palate to line the pharyngeal flap,
Yes, sir.
superiorly based pharyngeal flap. So that will be creating a lining for that, and that will prevent shrinkage of the flap also. Otherwise, what will happen? The flap will roll up, and it will see finally whether it is superiorly based or inferiorly based. After some time, it will be difficult to make out whether it is superiorly based flap or inferiorly based flap, unless the surgeon specifies it or we find the records. Because most often we
Yes.
have found this. Because in olden days, I mean, in my earlier days, we used to do inferiorly based flap also, but later we found that it is also being pulled up. So there won't be much of a difference. But the rationale set for superiorly based flap is it is dynamically favorable because it is pulling the palate up. Whereas the inferiorly based flap will act as a check rein, restricting the movement of the palate. That's why most people are favoring superiorly based flap nowadays. Then
Yes.
coming to the last statement made by Tejaswi regarding the Vanderwood, the sinus on the lower lip. See, you don't have to wait for the squamous cell carcinoma to develop for the excision. As he said, one significance is the cosmesis. Because
No,
whenever
no,
when the
sir.
child
He
grows
said
up,
Yes, ma'am.
it may develop with the squamous cell carcinoma. He said you
Chronic
will.
inflammation.
yeah. Now, the cosmos is also important because
Yes.
when we do excision on the lower lip, the scar will be vertical, which will be corresponding to the vertical folds of the lower lip. So it will not be prominent. So even if we do it at an early stage itself, it is not going to be of any issues. It will be giving a better appearance to the lip.
Yes.
Yes.
Thank you, sir.
That's all, madam.
Sharika?
Madam, I'm stuck with my computer. Give me 2 minutes. I can send it to Tejasvi. He can share it if that is possible.
I think Tejasvi, you have organized the spotters.
I have already made the PPT photos,
Yeah,
madam.
yeah. No, I told the Tejasvi also
Oh,
to put it in
to put it.
spotters.
Okay.
Do you have Tejasvi? Dr. Tejasvi?
Just try the settings.
Yes, ma'am.
Do you have spotters? You can project. Sharika's is not.
Ma'am, actually, it's not in WhatsApp, ma'am. Actually, ma'am, Sarika, ma'am, can you please send me, ma'am? I'll
Yes,
immediately
I'm
project.
send it to you. Yes.
Yes.
Can you just send me a message now, please? Your email message, email ID, please.
Email ID, yes, ma'am.
Send me on WhatsApp and I'll.
Yes. I have sent, ma'am.
Okay, please check now. I've sent it to you. Idenda Prashnanda security. No, click the lock to make changes. Oh, okay. Then I may be able to do this. Lock. Okay. Where?
This whole application.
I have to leave it and come. Can you see my screen now?
Yeah.
Yes, I'll put it.
Diagnosis, please.
Diagnosis and treatment.
Wait.
Just briefly, you tell. There is no detailed description and all. Tell the name of the PG who wants to answer.
I'm Dr. Tejaswidas, ma'am.
Yeah. If you want to answer, you answer. Or any of your colleague who is answering, just tell their name.
Yes,
Tell the
ma'am.
name of this PG.
I will be answering the questions.
Okay. Done. Proceed.
Yes, ma'am. Yes, ma'am. This is a case of bilateral cleft, ma'am. Having incomplete cleft lip on the right side and microform cleft on the left side, ma'am.
Is it microform or mini microform?
How do you define?
How do you define minor microform and mini microform?
4 mm, 2 mm. There is difference of based on the from the vermilion border, the based on the defect less than 4 mm, it's microform, ma'am.
Okay.
And it is less than 2 or a mini, I don't know, ma'am, actually.
Minor is extends 3 to 5 mm above the normal Cupid's bow.
Yes,
That is 50% or less of the normal labial height. Microform is less than 3 mm and mini microform is just a notching in the white roll.
Yes, ma'am.
Without any elevation.
Yes, ma'am. This is just notching, no, ma'am, then a mini microform.
Yeah, this is a mini microform on the left and a minor on the right.
Ma'am, this is Seminar's band, so can we call as incomplete?
Incomplete, yeah. It's an incomplete on the right. What is a Simonand's band, Tejaswi?
Simonand's band is just a skin attachment without any muscular attachment. It is the continuity towards the nasal cell.
Okay.
And the treatment for this this patient, I would proceed with the Millard's after investigation. I would proceed with Millard rotation advancement on the right side, and the left side I would not do any procedure. In the future, if patient requires any cosmetical correction, that can be done.
Yes, someone is asking something.
My junior.
Yes, if any doubts, he can clarify.
Can you please unmute the mic and ask the...
Yes.
Okay, ma'am. No one is speaking, ma'am.
Okay, next spotter. Would you like to tell anything, madam?
Yeah, you should be managing the left side also. You can do a Z plasty, but something has to be done to the left side. Ideally, it is a Z plasty in mini microform. Yeah,
yes.
It's a Z plasty at the white room.
Yes, ma'am. Spotter, anyone wants to answer?
Any other PG wants to answer the spotter? There are other PGs here.
Any PG can answer. Not only Kilpauk.
Ma'am, this is a case of... I'm answering, ma'am. Shall I?
Okay, answer.
This is a case of unilateral cleft lip, alveolus and palate, ma'am. Group 3 cleft, group 3 according to Nagpur classification. And the tooth is erupted, so the age may be more than the upper incisors. It may be the age more than 15 months, 11 months or 1 year. At this stage the secondary palate and lip is repaired, and followed by the primary palate repair in the later stage. And there is required, ma'am.
You do lip as well as the primary palate, or in different stages?
Primary palate is done different stage, ma'am.
Means Along with the lip repair, do you do any other procedure for this?
Along with the lip repair, I would also reconstruct the nose, ma'am. Primary rhinoplasty should be done, ma'am.
Anything else? What problems you will face in closing this lip?
The arch, there will be arch discrepancies, ma'am, and tooth eruption will be problem.
No. You directly go for a repair, or which type of repair you want to do?
I would go for a lip Millard rotation advancement, ma'am.
Is there any criteria to select the Millards or Tennyson Randalls?
Yes, ma'am. The defect is less than 4 mm, ma'am. The Tennyson Randall is preferred, and also more than 4 mm.
Less than 4 mm or more than 4 mm?
More than 4 mm. Sorry. And that's all, ma'am.
So, is there any difference in repairing this and the incomplete cleft lip?
Completely.
It's almost a wide cleft, isn't it?
Yes, ma'am. The nasoalveolar molding, but it is less than means 6 weeks. That in the early stages, the nasoalveolar molding can be done, ma'am. To decrease the cleft, ma'am.
Yes.
To decrease the cleft width, ma'am. We can do nasoalveolar molding, which is maybe active or passive. But
to align the arches to decrease the width of the cleft, you have to recommend from the beginning. Okay.
Yes, ma'am.
Yes. Is there any need? Will there be any need to advance the lateral segment?
Yes, ma'am. Lateral segment should be
do that?
the cleft by giving the Millard advancement rotation along with a triangular flap modification can be done, ma'am, to further advance.
The muzzle dissection should be a little wider away and lateral in subperiosteal or the supraperiosteal up to the infraorbital foramen. Okay.
Yes,
so unless you mobilize the lateral segment, the wide clefts cannot be closed without and sutured without tension. Okay.
Yes,
so that you have to do. And along with the lip repair, you have to do anterior palate repair also in group 3 clefts.
Okay, ma'am.
Okay, the anterior palate repair means the nostril floor, nasal floor repair has to be done. That is nasal layer of the palate you have to do along with the lip.
Yes, ma'am.
Then only you can prevent the development of the fistulas. Anterior, pre-alveolar, post-alveolar fistulas, all these things. Okay.
Yes,
it will facilitate your palate repair also at later date.
Yes,
Madam, do you agree with me?
Ma'am, first is the more than 4, less than 4, ma'am. It is more of a surgeon's preference, I think.
Yeah,
classically that will
for yes.
Whoever does Tennyson will do Tennyson in every case. Whoever does Millard will do Millard in every case. Ma'am, usually there can also be a method of closing the nasal floor along with the anterior palate in the first go.
Yes. Yes. Yes.
Then it is easier to close the palate later
Yeah.
on.
Yes.
Yes.
Trikumar sir, you would like to tell anything?
Madam, regarding this 4 mm, less than 4 mm, more than 4 mm, it depends on the surgeon.
Yes,
Of course,
because now
there are
widely used the Millards, they are doing in various centers for any type of cleft, the
exactly,
Millard. Yes, where
exactly.
they are
There
doing
are,
the tennis and Randall, they are preferring for wide clefts the tennis and Randall method.
yeah,
Otherwise,
because
narrow everywhere, this is Millards is preferred, sir.
Millard is being done. Previously,
Yes.
the teaching was for complete clubs, triangular flaps, and for incomplete clubs for Millard flaps.
Yeah.
But
Yes. Sir.
there are centers who are doing Millard for both complete and incomplete, and
Yes.
some other centers they are doing triangular flaps both for complete and incomplete. I prefer
Yes.
to do Millard for both, and
Okay.
I feel comfortable also. The advantage is revision is in case if revision is necessary, that is easier with Millard.
Okay.
One thing.
Yes,
The
yes,
second
it
thing,
is.
yeah, as you said, primary palate repair also is advisable in the first stage itself to avoid to reduce the chance of fistula.
Yes. So for PGs, whatever they do in their institute, better to tell the same method.
Yes, ma'am.
So that will be accepted by the externals also, because your internals will support you.
Yes,
Okay.
ma'am. Yes, ma'am.
Shall we proceed for the next spotter?
Yes, ma'am.
Yeah. Who is going to answer?
I think all are in hold, ma'am, actually.
Okay, you won't answer.
I'll answer.
Yeah.
This this patient has a right side microform.
No, 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 no.
Minutes band, incomplete left, ma'am.
This is a mini microform, Tejaswi. This is a mini microform. This is only a notching in the vermilion, nothing else, and a very minor nasal deformity.
Ma'am, is this called
There
as
is
a
something is
because
there in
this is a mini microform.
minutes band, ma'am? Can this be called, ma'am?
No.
No,
It
no,
is
no.
not
There's no
seminal
seminal
band,
band.
but there is a small black thing extending there. Whether the muscle is decent there or not, we don't know.
Muscle will
Unless
be
it is
decent. Yeah. Muscle will be
because
decent.
the upper part of the lip also it is little like scar-like tissue. Maybe it's only yeah.
Yeah, this is microform or mini
Notching is
microform.
there?
This more.
Yes.
There is a small notching. There's a small notching, but the
Yes.
cupid's bow is not
Upper part.
raised.
Okay.
There has to be a difference of at least 2 mm between the two, which is not there.
Yes, ma'am.
Mini microform is difference between the height of the cupid's bow. That is not there. It's just it is a notch.
Yes.
Yes.
So again, what will be the management?
Management is as ma'am told, Z-plasty can be done.
Only, ma'am. Yeah.
Yes. Next spotter.
This is an incomplete cleft lip, ma'am, on the left side.
Yeah.
The treatment is Millard rotation advancement flap.
Okay.
Okay. Next.
This is a bilateral. This is a baby with bilateral cleft lip, cleft palate, and protruding prelabium or protruding
Premaxilla.
Premaxilla prolabium. Okay. So what is your management from starting till end you tell for this type of baby?
The first
If the child comes to you at birth.
Yes, ma'am. I would first counsel the parents regarding the feeding and regarding the further procedures in the future. And the second thing, I would advise within 2 weeks of birth, I would advise nasoalveolar molding. And lip adhesion can be, and taping can is advised, ma'am.
Okay.
And
but the child comes at this point. Child comes at this point. You are seeing this kind of protruding premaxilla.
And
what would you
appears to be less than 2 weeks, ma'am. I would start with nasoalveolar molding.
No, this is a 6-month-old child. What would you do?
6-month-old child, ma'am. I would do bilateral cleft lip repair, ma'am.
How?
Can you
with
do
this kind of flyaway premaxilla? You can't do.
Yes, ma'am.
Until and unless you do something to the premaxilla, what would you do? That is my question.
You have to reduce this projection, no? How will you do it?
The pin, these must screws. What is that from? Stainless steel. We'll fix this with the pallet, ma'am. I'm not able to correctly tell you.
There's a procedure called premaxillary setback.
Setback.
Which is hardly required nowadays in developed countries, but we get these kind of defect all the time. So there's something called premaxillary setback. So there are different methods of premaxillary setback. You are talking of one of them, using a stainless steel wire to fix it.
Yes,
but even without that, you can do. You have to, tell me.
By suturing to the hard palate, to the palate or the bone which is intact, ma'am. We can keep the maxilla in intact position, ma'am. Pre-maxilla in intact position.
Easiest method is to remove a piece of marine. So you have to remove a piece of vomerine bone in front of the posterior nasal spine. You don't go behind up to the posterior nasal spine.
Yes,
you can just raise an H-shaped flap like what you do in an iliac crest bone graft. You can remove a piece of bone and you can stitch back the flap. This will fall back in position and the muscle closer will keep it in position.
Yes.
If you go through McCarthy, it is mentioned there because premaxillary setback is no longer there in the newer books.
Yes.
It is there in Converse and McCarthy. And
surgical
when you do that
setback, it is nowadays they are not practicing, no, ma'am.
Yeah, because they don't get this kind of scenario. If the nasoalveolar molding is very correctly done or taping and hooking is done, then this kind of scenario doesn't arrive. We get these patients primarily at 6 months, 8 months, 1 year.
Okay. So you do the surgical
and what is the
setback?
Ma'am?
Yeah.
Okay.
And there is only one precaution. If you do that kind of setback, you don't correct the nose at that setting because then you will be devascularizing the flap totally.
Yes, ma'am.
You can't do the nose.
Second stage.
Yeah.
Yes.
Will you do any lip adhesion and all for this type of cases?
Not usually, ma'am. A setback suffices. Usually. Till now, I haven't done an adhesion.
What about gingivoperiostoplasty?
No, not done primarily, ma'am. Gingivoperiostoplasty. GPP is done at 7 or 8 years of age with alveolar bone grafting.
Oh, simultaneously you do both.
Yeah. GPP, primary GPP, we don't practice. We usually do the primary alveolar, the anterior cleft closure along with the nasal floor closure with two layered closure. Because the alveolus is never that aligned, ma'am.
Yeah.
The kind of patients that we get, we don't get an aligned alveolus at that age. Until then, unless they do the orthodontics beyond 4 or 5 years of age, we don't get an aligned alveolus.
Yes. Sri Kumar sir?
Yeah, yes, madam. We have been discussing on this bilateral cleft lip. Some other findings are there also for the child. Did the
Yes.
notice that?
Epicanthal folds and
so it looks like
cranial
child is a
problem.
syndromic child.
Yes.
Yeah.
Down.
So telecanthus is there, epicanthus inversus is there.
Yes.
So it looks like a syndromic child.
Down.
And of course, as Chatterjee madam said, I also would prefer to do the at this stage. If the child is coming late, I prefer to do a premaxillary surgical setback. But nowadays, very rarely done. Surgical setback.
Yes.
Because we get children much earlier, so that prealveolar molding, surgical molding will be enough. But once it comes late, of course, we have to go for surgical. And I also don't prefer to do this gingiva at the first stage itself. I would like to do it at a later stage with this.
Okay. Anything you would like to ask?
No, this is about the cleft lip and palate, but other, I think the candidate haven't mentioned about anything about, so I don't want to ask anything about that. Okay, madam.
Which type of repair you prefer, madam, in this case? Lip. What do you do? Mulliken.
Mullikens repair. Bilateral mulliken. But I usually put a median in all bilateral cleft. I usually do Dr. Murthy's median tubercle technique. Jyotsna Murthy described it 3-4 years back. It's a very beautiful way of adding the median tubercle to the mullikens.
Okay. Sri Kumar sir?
Yeah, madam, I also prefer to do the Mulliken's technique for this sort of clips. Yeah.
Okay. Next photo we'll go?
Yes.
You want to ask anything about alveolar bone grafting and all? Okay.
This is also a very typical slide.
Yes, ma'am. This is present on the secondary palate. The diagnosis may be the nasopalatal fistula, ma'am.
No. This is a primary case. Look at the uvula. Look at the uvula.
Uvula. Some triad.
It is a bifid uvula.
Bifid.
So what is the diagnosis?
What could be the diagnosis?
Submucous cleft.
This is a submucous cleft palate, right?
Yes.
So what is the Callan's triad?
The bifid uvula with a submucosal cleft and
with the muscular diastasis and a notch at the
posterior
palate, right? What will be your management?
Submucosal cleft, the palate. Not sure, ma'am. Not sure about that.
Furloughs. Submucosal is always furloughs.
Furloughs.
Management is furloughs. Yeah.
Yes.
As there is dehiscence in the hard palate also, so you need to repair that also, isn't it?
And
Yes.
that is, yeah.
Because this is unusually, it's involving even the
That is in the soft palate only. That is in the soft palate only, ma'am.
soft palate. Okay.
Yeah, yeah. This is the hard palate. This is
Palate,
the junction of the hard palate. It is
oh,
about 1
junction
centimeter.
between the hard and soft palate. That is.
Yeah, yeah, yeah.
Okay. Right. Okay. Next photo.
This is the unilateral cleft palate, ma'am. Sorry, cleft palate, ma'am. Involving the secondary palate, with the omer exposed on the right side.
Yeah. View classification.
View classification. The group 1 only cleft palate is involved.
No, this one is view what?
The secondary palate. View 2, ma'am.
See, there was a view 3. There's a unilateral lip here. See?
Lip also is there.
Yes.
View 2 is cleft of secondary palate only. Secondary palate.
Yes, ma'am.
View
This is
3 is
view,
one side.
Lip.
view
I
3.
not appreciate lip, ma'am. The lip is there, ma'am. Nasal cell. I now appreciate it. Yes, ma'am.
See the nose on the left side? It is a unilateral lip was there. So,
Yes, ma'am.
management.
The management is 2 flap palatoplasty with intravelar velopalatoplasty. Veloplasty.
Veloplasty. Yeah.
Veloplasty.
Okay.
Okay. Any more are there? Any more spotters, or this is the last one?
Yeah. Last one.
This.
Yeah. Yeah.
The uvula. Incomplete cleft palate. Secondary involving only soft palate.
This is view 2. This is view 2.
View 2.
This
The
is
only
secondary.
second palate.
For group 2.
Group 2.
Soft and part of hard is involved.
Soft and part of hard, yes.
Yes.
Is in this I'll proceed with VWK palatoplasty, ma'am. The partial, since it is not complete.
Okay. You can also try a Faldo here. A Faldo might be sufficient.
Yes, ma'am.
With lateral releasing incisions.
Yes, ma'am. Lateral releasing incision. Yes, ma'am.
Okay.
Okay.
As we completed the spotters.
Yes. Yes, ma'am. Last quarter.
Yeah. Okay, Tejaswi, you presented the case as well as answered the spotters. Very nice. Good.
Thank you, ma'am. Thank you, ma'am.
Today we learned about an precise way of all details of the VI velopharyngeal incompetence and cleft lip, the clinical presentation and various types of cleft and the management. I thank everyone who has participated in this session and contributed. I thank Dr. Chattopadhyay for sparing the valuable time and nicely discussing the case. Dr. Sri Kumar sir and Dr. Bhattacharya sir, he could not continue till the end. And I thank each and everyone for sparing and contributing your experience. Thank you one and all. Saturday again we